Yeah, so I'm going to review this very interesting and short abstract. The presentation is by Dr. Zoran Andrik. The title of the study reads, first-line avelumab in combination with cetuximab and chemotherapy in patients with advanced squamous non-small cell lung cancer. Next slide, please. This is a very short study background and scientific rationale of this combination. We all know the avelumab is a fully humanized IgG1 isotype monoclonal antibody directed against PD-L1, which is present on tumor cells. It is unique from other checkpoint inhibitors in that it has a dual mechanism of action. It can inhibit the interaction between PD-L1 on tumor cells and as well as on the and the PD-1 on the T cells, thereby preventing the immune escape, inhibiting the immunosuppression in the tumor microenvironment. The other unique thing about this is that it can activate the NK T cell, it can mediate the antibody-dependent cytotoxicity, and thereby directly targeting the cancer cells. This is because of IgG1 isotype with retained FCR in the avelumab. So this is the two unique mechanisms that avelumab presently has. And avelumab presently is approved as a monotherapy in first-line setting in Merkel cell carcinoma, and in second-line setting as a monoclonal and as a monotherapy in urothelial carcinomas. And recently, it has approved for renal cell carcinoma in combination with axitinib. So here, the scientific rationale for the combination with cetuximab is that cetuximab also is an IgG1 isotype monoclonal antibody directed against EGFR, and it can also activate a functional crosstalk between the NK T cell and dendritic cells, thereby priming the immune system by recruiting more cytotoxic T cells in the tumor microenvironment. And the hypothesis is that it can be more sensitive to immunotherapy. And the combination therapy may also be able to activate both innate and adaptive immune responses by engaging different types of immune cells. As already been explored in the keynote studies, the chemotherapy combination with immunotherapy increases the immunogenic cell death by increasing the tumor infiltrating lymphocytes, CD8 positive T lymphocytes, and NK T cells. Next slide, please. So this is a very short study. This is a phase 2A single-arm multi-center study, basically from Europe. It was investigating the clinical activity and safety of avelumab in combination with cetuximab, in combination with gemcitabine and cisplatin chemotherapy in advanced non-small cell lung cancer, who are treatment naive in the advanced setting. The key exclusion criteria are that patient with brain metastasis, patient who are having performance status of 2 or more, patients who have taken systemic therapy for the advanced setting, and also patients who have taken immunotherapy at some point of time. The treatment intervention, the study intervention is avelumab, dosed at 800 mg flat dose on day 1, day 8, cetuximab 250 mg meter square on day 1 and 500 mg meter square on day 8, with cisplatin gemcitabine, which is usual dose, gemcitabine at 1250 mg meter square and cisplatin 75 mg meter square. 4 such 3 weekly cycles are given, and at the end of 4 cycles, who are patients who are having a stable disease were delivered with avelumab and cetuximab at 2 weekly as a maintenance therapy until progression or toxicity or withdrawal of the consent. The primary endpoint of the study is best overall response. Secondary endpoint included the safety analysis as well as median PFS and median OS. And also it had several pharmacokinetic and as well as biomarker data. Next slide, please. As I said, it's a very short trial. Around 43 patients were enrolled. At the time of primary analysis, which is July 2nd, 2020, 15 patients, that is 35% of patients, are still remaining on study treatment. The confirmed best overall response rates was partial response in 13 patients. There were no complete responses, making the overall response rate of 30%. This is control rate, which includes both the stable disease and partial response, nearly 80%. Median duration of confirmed response was 7.1 months, and event-free survival at 6 months was 61%. So the treatment-related adverse effects, all grade, were present in nearly 90% of patients, and grade 3 was present in 56% of patients, with neutropenia being the most common at 28%. Next slide, please. So fortunately, there were no treatment-related deaths in this trial, and the updated analysis at November 4th, 2020 was showing the median PFS of 6.1 months and overall survival of 10.0 months. We don't have the biomarker data yet. We don't have the updated data, which is yet to be presented. So based upon this analysis, the authors have concluded that the combination of avelumab, cetuximab, cisplatin, and gemcitabine is showing a very good clinical activity and manageable side effect profile. They have not noticed any additional safety signals with the combination of avelumab and cetuximab. So my take on this is it is a very interesting hypothesis. This trial, albeit small, was generating enough data to surely explore this in a phase 3 manner. Surely biomarker data will add more value to decide which subgroup of this squamous cell advanced non-small cell lung cancers will be benefiting more. And the focus should be from the investigators to add biomarker-based patient selection in the phase 3 trials, and to guide the clinicians to have an extra armamentarium for the management of first-line management of small cell lung cancer, especially squamous cell lung cancer. Thank you.